the other aspect, of this decision making is, Dr. Baer, if you can, tell me and to the group here, do you address the chemotherapy eligibility to the patient, or how do you decide that? Do you just leave that up to the medical oncologist? And tell me, how do you think about that?
In my practice, I'm in solo practice, and so I usually will try to have that discussion of kind of the expectation, doxycycline, triple line therapy, having the androgen, receptor inhibitor, the agonist. So having that whole treatment protocol, for certain urologists in certain practices, it's overwhelming, having, you don't have the ancillary staff to get the prior auths for everything. But in my practice, we're able to do, whether it's Lupron or Eligard, whatever, we're able to at least start that process. Mm-hmm. And I always say, if you have an advanced prostate cancer treatment in your practice, and there's several practices that have that opportunity, I think that's great. I always say you kind of want to do as much as you can within your own practice, before getting the oncologist involved. But in my practice, I kind of get it started, kind of set the expectation, maybe go a little bit through some of the expected side effects, because the worst thing is not preparing the patient. Yes. And I always say, if we over-prepare them and then they get the symptoms, then you've done your part. If you don't tell them they have it, then I feel that we didn't do our, the right thing. But I try to get them started, and then I have a really strong relationship. I've probably got 4 or 5 different medical oncologists in town that enjoy prostate cancer treatment. So, it's really just picking up that phone call. 30-second phone call goes a long way.
Yes. Yeah, no, this is great insights. I think, really, we are really enjoying the benefits of these new drugs. And really, I think at the end of the day, it's the patient who are the beneficiary of this, and we really need to put their, interest in front of us. So I think this is very exciting collaboration. So I think moving forward, as we know, the Arasens trial has some really exciting, results with the triplet therapy that has shown a significant improvement in overall survival when you add to the chemotherapy. And so I think that has really become the new standard of care for metastatic hormone-sensitive prostate cancer. And in our practice, we have a similar, understanding with our urology colleagues that, they would start them on ADT, can be Lupron or Eligard, and, they will be on my way to do the genetic testing and then start chemotherapy and so forth. So I think it has worked out very well for our practice, and it seems like you all have a really good understanding with the community oncology practices. So, I think moving forward, do you have any experience with the darolutamide in terms of the side effects, management, or if you can say your experience on that?
So it's a newer medicine, so we don't have tremendous one-on-one with it, at least from our perspective, because remember, our day is prostate cancer, kidney stone, yes. Kidney cancer, bladder cancer, yeah. Leaking, ED, but very well tolerated. Each of those medicines that are used to complement the ADTs have their issues, but so far so good with the darolutamide. Good. Patients are doing well. We're getting it available through their insurances, which has been a blessing. So far so good.
So you have not had any issues from the insurance access point of view?
Not yet. I don't think I've had to make a substitution yet for it. Not that I can think of.
I think the side effect profile for darolutamide is probably the most attractive aspect of prescribing it, comparatively speaking to the 3 other medications that are more commonly used in this space. What I also will highlight, and I think is really important, is the industry support, because it's not necessarily the urologist. We're prescribing it, but we are not going through the paperwork. We're not going through the hassle of making sure the patient gets it through a third-party pharmacy that provides it and helps cover the cost. But we do need the appropriate representation on the phone for my medical assistant to say, hey, patient needs to get it. We're out of samples. We're running behind on a prior auth. How do we get treatment started? And industry support is crucial for these medications, particularly, again, because they're new. Not all urologists are super comfortable prescribing them. Yes. So if you have a phone a friend or a helpline to say, how do we get this started? We really need it for the patient. That makes all the difference. Otherwise, the patient will sit and kind of float out there waiting for you to finish your day after you're incontinence, renal cancer, bladder cancer patient to finally address, hey, I still haven't got my medication and the pharmacy's closed now, so how do we navigate that? So that has led to the success, at least in my practice, when my MA can call up our industry rep and say, hey, Mr. So-and-so needs his meds. Oh, wait, guess what? We've got some samples to get things started, whatever the case is.
Yeah.
Really important.
Excellent. Yeah, no, I think important. I think, end of the day, having drugs available to the patient is extremely important. And it looks like, the industry is doing everything they can on their end to help, the physicians and to the patient to get access to these drugs.
Access is probably the most important.